Good morning. It's wonderful to see all of you here, and I'd like to welcome you to Achieving Excellence in Healthcare through Patient Engagement. We have a day that's planned with both some speakers who'll bring you innovative ideas, some discussion from patient advocates and patient advisors, but also a chance for people really to do some talking and some networking. I want to spend just a minute to introduce myself. I'm a member of the CareOregon Board of Directors. I'm very happy to sort of be your traffic control director for today. And we'll try and make sure that we stay on time as I moderate this. I do want to make a quick correction to the program notes, because one of the things you'll notice in your package is that you have biographical notes. You have a list of people who are attending this. You have an agenda. You have some information on our sponsoring organizations. But just as a matter of correction, I am retired. Everything that's in there is true. It's just that I did it before today. So the one thing I haven't retired from, though, is a really passionate interest in improving healthcare and the quality of the healthcare system that we have. Now, I want to do one other thing before we start with the formal program. I want to thank our sponsors and the talented employees that they made available to put this program together. Angela Mitchell of the Providence Health System, Tamara Petrojetti of CareOregon, my own organization, Summer Buslaw of Quality Core, and Patty Black from PeaceHealth. All of them have put a significant amount of time and energy into this, and you will see them all at other parts in this program. So if you don't mind, why don't we just give them just a little bit of applause? I also want to make you aware of what's going on in the back of the room. You might have noticed that we have some big pieces of blank white paper back there that are being filled in. We've all heard the expression that a picture's worth 1,000 words. Well, this is an effort to see if that actually works. We are going to be capturing the messages that are part of this program using a new technique, or a relatively new technique. Some of you may have experienced it, visual minutes or graphic recording. One of the things that we've learned is that people maintain so much more information if they can see it visually, that you have much more of an opportunity to see the big picture and to make connections. So we're going to use that tool today, both for the meetings here and the meetings downstairs, and you will all get an opportunity to see what comes out of that process, and that'll be the way that we give our feedback back to you. We have really simple goals for this meeting. We really want to try and achieve a better understanding of why partnering in patients is really a key piece of achieving real family and patient-centered care, a major part of a quality healthcare system. We are hoping that all of you leave with some new and some effective ways to partner with patients, that you share your expertise and you take advantage of the expertise that's in the room. And very importantly, we hope that what this meeting gives you is an opportunity to network with others, to network with executive leadership, but also with patients who are here in the room and who are willing to share their stories and their expertise with you. Now, I'm perfectly on time, and I'd like to move into introducing our keynote speaker. It's my very great pleasure to introduce Anna Roth. She is the Chief Executive Officer of Contra Costa Regional Medical Center and Health Centers. It's a public hospital system in the San Francisco Bay Area. Ms. Roth has spearheaded improvement efforts throughout her system, and they include the introduction of the Institute for Healthcare Improvement's Model for Improvement, and also the Toyota Productions Lean System Management. Very importantly, she's committed to engaging frontline staff, both to drive change and to make sure that there is a culture of continuous improvement. She established a Change Agent Fellowship in her organization to cultivate leaders from within the system as local redesign experts. And any of us who have worked in organizations know that if you can't take change down to the front lines of an organization, you really can't achieve change. She sees the inclusion of patients, families, and community as an essential piece of transformation and includes them as full partners in delivery system redesign. She's played a key role in advancing healthcare reform and joint performance improvement with public hospital systems, safety net organizations, and government agencies. In addition, she's a registered nurse with 25 years of healthcare experience, holds a master's degree from the University of California, San Francisco, and an MPH from Harvard. She lectures at the Berkeley School of Public Health on healthcare quality, improvement, and measurement. And in her spare time, she's a blogger. And so in your notes, you'll find her blogging address, and it's a wonderful way to get to know and track somebody's work. So I would encourage you to take advantage and take a look at her site. And now I'd like all of you to welcome Anna Roth to the stage. Thank you.
Good morning. Thank you so much for that kind introduction and that generous introduction. I too am just so grateful to be here today with you all. I want to thank you for bringing me to talk about one of the things I'm the most passionate about, which is engaging patients and families in their care. And I want to start off by saying how many, just kind of polling the audience a little bit, how many formal leaders are in the room? Leaders. How many CEOs are in the room? Fantastic. How many patient advisors are in the room? Oh, great. This is great. So thank you for taking the time taking time out of your day to be here. I want to talk about a little bit about my summer. I don't get out very often. I was able to go on vacation this summer. I took a week out and I went to Alaska on a cruise. So I was actually sort of traveled through Oregon and Seattle to get to my port. So I got to spend some time in this beautiful region. But while I was in Alaska, I was on a cruise ship, which is a whole nother story. I don't know if you're a cruiser or a non-cruiser. I found out there are cruisers and non-cruisers, and I won't tell you which category I'm in, but your phone doesn't really work. So by the time, I mean, it works here and there, but by the time I really got off the ship and by the time I came back, I had about 1,000 emails waiting for me. Sound familiar? I think like I have a whole thing about email. I think we overuse it. But in the process of scanning my email, which is what I always kind of try to do the weekend before I come back from vacation, I think I'm going to just scan my email and see kind of what's in there. I came across an email, and I want to just tell you that there was a lot of problems. There's a lot of problems in my emails. I feel like almost every approach to me in my office, either via email or for a meeting, is usually an ask for a resource. Usually somebody wants an FTE or they want some money. I mean, it's very common. Or if it's managing upwards, they want me to cut something. So that's sort of. So I kind of scanned through those, 600 emails, and I came across an email about an incident that had happened the weekend before. And I just want to tell you, I want to read to you what my response was to the email, and you'll get the gist of what was in the email. And this was written to a nurse. I wrote to a nurse, and I wanted to write because I was so moved when I heard of the case yesterday about you, along with the members of the emergency department and nursery staff, treated an infant who was attacked by a dog and suffered critical injury. Though this was a horrific tragedy, I heard that the CCRM team were superb. I'm told that the baby is alive and recovering from their critical injuries at the trauma center. I know that you have been in touch with critical incident debriefing regarding follow-up support for all the staff involved. I've been told that you've been of great support to the staff and have a plan to ensure any of the staff who wants further support will have access to that. I'm truly grateful for your leadership. I wanted to let you know that as I was investigating this, I was also informed of your support of the child's mother. I was told that the mother was in the car, covered in her child's blood, in shock and too frightened to come into the ED. She was afraid of what she would find. I heard that you went outside, sat in the car with her, you prayed with her, and when she was ready, you brought warm washcloths to her and helped her clean up. I heard that with your support, the mother was able to come in and see her child before they were transferred. Too often we don't take the time or have the opportunity to tell someone how much of an effect they've had on us. The story of you washing this frightened mother, the deep compassion and sincere support you provided her will most certainly be one of the proudest moments I have ever had as a member of the CCRMC family. Beyond the superb medical care this child was provided at CCRMC, you and your compassion made a difference for this child, his mother, his family, the staff around you, and all of us. You are a shining example for us all. Gratefully. So I just wanted to share that with you because out of the 1,000 emails, I only responded to one, and that was the one. And so we're going to talk about, as a leader, how do you spend your time? I'm going to offer today, we're going to go over your role in involving patients and family members in safety and improvement efforts. What can you specifically do? What are the common barriers, which I think we probably all, if you're in this room, you probably already know what they are because sort of by virtue of selecting in to be in this room, I already know to some degree I'm preaching to the choir. But we're going to talk about common barriers that we all face and then some potential very simple steps that we could take to advance patient and family-centered care and services in our organization or our community. So here's the backdrop. We're in the middle of healthcare reform, right? I kind of put up this, I put this up because we can't help but this is happening around us. It sort of seems to set the context for almost every talk that we have. So what are the kind of the new rules related to healthcare reform? So the new rules are that there's going to be coverage expansion, right? So additional millions of people will have access to coverage. There will be Medicaid expansion in some places, hopefully eventually all places. There are exchanges being set up across the nation. But some people still aren't going to have health coverage. So that's one of the things. That's kind of up in the upper, my right, your left, right? So there's going to be payment reform. So quality is going to be emphasized. Volume is going to be de-emphasized, and value is going to be emphasized, right? So not necessarily all about volume and utilization, though non-utilization is going to be emphasized. Incentives and disincentive programs are popping up everywhere. We're seeing them come up with, in many states with their waiver programs. We're seeing them come up. There's a lot of different pay-for-performance type of programs that we're seeing. Markets are changing. There are new roles for all of us, for us in the delivery system, for us in managed care. We're starting to play new roles. Managed care is getting much more involved in delivery. Delivery is getting much more involved in sort of regional efforts. And then there's all the nonprofits, which now we realize, particularly those of us in delivery, we need to forge relationships with. There are many, many opportunities, and there are many, many threats. And then finally, there's really a new emphasis on shared risk. So these standalone approaches, these standalone independent systems may need to rethink, we're seeing them rethink across the nation. They're rethinking sort of their structures. We're seeing accountable care organizations and coordinated care organizations here in Oregon, regional information exchanges, care collaborations, regional cooperatives, you name it, all really seeking better health care, and delivering that at the lowest cost. And so no matter how you operationalize health reform, I know you're all engaged in it on some level. So I'm going to talk about, I'm going to be contrasting a lot here between what we as the leaders and the formal people in the system, let's say that make up the system, how do we view our system, and then how do others view our system, and mainly how do the patients and the family members and our community view our system. And I would be safe to say that, does anybody not have an org chart for their system? You don't have to raise your hand, but I'm guessing you all have an org chart. In fact, if I came to visit and I was coming for a sort of formal visit, you would give me the org chart so I could make sense out of your system. And you could, this sort of shows me how information flows, that this is really a power distribution. It's a privilege distribution. And so this is sort of, and this is how I view systems very often, or how I often did. But actually, our systems can feel a little bit different to the people on the front line, and particularly patients and family members. And they're feeling a little bit more like this. Kind of after really the top couple rows here, it just kind of falls into total disarray. And I think that probably all of our systems, really function in this way. I don't think there's really any systems that don't. And I think that as leaders, I think this is there we go. We have very little chance of understanding what's going on down here, down here at the front line, unless we go there. And that's going to be one of my points to you is we're going to have to go down to the front line to understand. But this really, if this is our view, which this is my view, this was my view as the CEO. If this is your view of the system, then you're missing what's really going down here. And who are the experts at what's going on down here? Right? Patients, that's right, patients, family members. A lot of people will say frontline staff, but I would say frontline staff also kind of have this view. They kind of just start in their piece of the world, and they still have an organized view, and from their perspective. But really, the people who really know about this chaos are the patients and their family members that are actually trying to navigate. That's why I crack up when everybody goes, "We're going to hire navigators." Really? Now, if you run a navigation program or you have navigators, I think that's great. But I'm just saying that part of it is, maybe putting in navigators, but part of it is creating something that the navigators would have a chance to navigate through, which, they wouldn't in this case. So this is how many of you track your safety events, you all do, right? All your systems have some kind of tracking of your safety events. And this is much, what we look at generally. When we go to our monthly quality and safety meetings, we look at our rates of safety events. And these are, looking at, reportable events. And so, but this is not really how patients and family members see our safety events. This is much more the way that it looks to them. So this is, Tammy, who had a post-procedure death, and baby C, who had a delay in treatment that resulted in a hospitalization. Donald had a delay in treatment and found out later he had cancer, and he was at stage 4. Retained foreign object, right? We all see that, but for Herman, that meant the difference. He couldn't run a marathon that year. So it's a very different way. We're spending our time looking at it from this perspective, but actually this is what's really happening to people that we treat, the people that our missions say we're here to serve. That's what's happening. And some of us have started to talk and tell the stories. Some systems, I think, very powerful, start each of their meetings, their safety meetings in particular, with the story. They maybe talk about baby D, and they tell the story. In our last safety and performance improvement meeting and our medical executive meeting, our medical director of quality started off with a medication error involving a physician. And at the end of the story, it turned out it was her, and it was just about 3 weeks ago. And so it was very, very powerful for her to sort of tell that story. And say this is not something that's happening somewhere else. It's happening right here, and it's happening here. And I mean here as in all of our systems, right? And this is just sort of shows kind of the skew between our two views. It's not clear the way we view things and the way patients and family members view things are very, very different, and the way the community views things. And often the community. If we have a really good PR department, the community may, get an even more skewed view. I'm just being very, very, very honest. So This is, again, another way that we sort of look at things. We talk about never events in the hospitals and in our health centers. And these are shocking events that should never occur. Things like a retained foreign body in surgery, or falls, or stage 4 bed sores or pressure ulcers. These are very, very horrendous things. And so we're counting that, right? But there are some systems that have said, you know what, we can sort of move beyond this sort of counting our defects, right? We can move beyond that, and we can actually instead start to count our promises that we're making to the patients. And so this is just a different perspective, and this is around systems that have really moved, some systems have moved beyond never to always events. These are really promises that they're making to every patient. This will always occur. And so here's an example at Iowa Health. They will always listen. This just seems really basic, doesn't it? They're going to always listen to the patient during handoffs, and then they're going to do teach back. I know that sounds really, really basic, but this teach back method, this has been, there's evidence that says this is sort of one of the #1 drivers of reduction of readmission rates. Yet we don't do that consistently. We're doing all this other stuff, but we don't do something as simple as that. At Iowa, they always do it. At Dartmouth, they are going to always communicate with the patient and inform them with respect through the following behaviors in every patient encounter. And I didn't write the list to you, but it was something like, we're going to smile at you. We're going to say hello. It was so basic. It was unbelievable. And so I just want to ask you, in your system now, this is a question to you. This is about 3 years old data now, but it still remains, sadly, it's still pretty consistent, and that is that pretty much all, most 95%, about 95%, 93 healthcare leaders say that patient experience is among their top 5 priorities. And so how many of you is it not among your top 5 priorities? Anybody? Yeah, so see, 100% of this room. And then and these are like CEO types now, while 72% of them say that it's one of their priorities, only 1 in 8 CEOs actually takes the primary responsibility for patient experience and engaging patients and family members. Only 1 in 8. So what does that say? Again, I'm going to talk a lot. You're going to hear a repeating theme to the CEOs in particular about how you spend your time. And how you spend your time is a values statement, and it's a very powerful value statement. And I think it's a very simple thing that you can change right now, today, this afternoon. And I think that it's underestimated how powerful it can be by just some slight tweaks to how you change your schedule, how you view your email, which email are you answering first, And believe it or not, your system is watching you. They're paying attention to what you're doing. So now I'm going to give you a little bit about Contra Costa Regional Medical Center and Health Centers. Just because I'm going to give you an example, because for those of you keeping score, I like to give a little bit of results so you don't think I'm just sort of standing up here just sort of preaching philosophically. We are a public health system in the San Francisco Bay Area, as was stated. We exist in a county of 1.1 million. We have 1 hospital and 8 health centers. We're doing about 12,000 discharges a year and about 450,000 outpatient visits. We also have a health plan, which has both commercial and Medicaid products. And we also coexist within the public health department itself. So the health department contains all of that. And we also own and run the EMS system. Also, we run the jail detention health systems. So we have a family medicine residency program, and we have 43 residents a year. It's a very popular program. But what we don't, so primary care is the prominent feature within our system. We don't do transplants. We don't do complex surgeries. We don't do we don't do bariatric surgeries, that sort of things. What we do is we do common things and commonly well. So we are the primary care feeder of the community. We are we do primary care. That's what our specialty is. So how we began was really, I would love to stand and tell you an altruistic story. I'd love to say, one day, we kind of became enlightened, and we realized that the right thing to do was to engage and involve patients and family members. But that is not the way it happened. So let me tell you the truth. The truth is, I was the CEO for about 3 weeks, and it's a public system, as I told you. So our board meetings are public meetings. You sit in a public chamber. It's televised, and so I sat down to be introduced to the board, and during public comment, a long line of patients and family members were waiting to make public comments, and one after another, they told one horrific story after another about our psych emergency service and our emergency department, long waits in the emergency department, separating, no visitors allowed in the psych emergency department. One father of a 9-year-old boy told a story about his son being taken from him, and he could hear him screaming in the emergency department, and he was forced to sit out in the waiting room. He wasn't allowed because he came for behavioral health service. It was just one sort of shameful story after another. And so I had a choice right then. I could have sort of said, I've been the CEO for 3 weeks, so I'll get back to you on this. Or I could have done what I did, which was, and again, I don't know that I planned it out. It just sort of, this is the way it happened. I said, well, I invited many of those patients and family members, in fact, all of them, to come and help us improve the system. I wasn't sure if anybody was going to take me up on the offer, but of course they did. And that's when, I'm sorry this isn't so clear, but this is Teresa Pasquini. And you're going to hear me talk a little bit about patients, family members, and I also brought a video because I don't like to actually do a talk like this without a patient or a family member with me in the room, because I feel like it's their story that drives change, not my story. So I do my best to share their perspective. But Teresa was a mother of a boy who's now a young man, who had been in our psychiatric emergency department 72 times. She had also been in every other hospital's emergency department in the region. We have 9 hospitals in the county. There wasn't one hospital they hadn't been to. So, this was sort of a regional, this wasn't our issue, this was our issue. And it wasn't her family's issue, it was all of our issue. And so Teresa said, I'll help you. I'll help you change the emergency department and the psychiatric emergency department, and I'll bring my friends. And she showed up then. At the time, it was said in the bio, we were doing Toyota production system. We were doing what's called a Kaizen event. It's a rapid improvement event. It's a 1-week-long, big, glitter everywhere improvement event where everybody gets in a room, they brainstorm, they run out with clipboards and they time things, and then they introduce tests and they study it and they make changes. And so here comes Teresa with 14 of her friends to come and help us do improvement. And the consultant said, that were helping us, the lean consultant said, what are you doing, here? What are you doing with all of these people? And we said, well, we're going to do improvement. These people are going to help us improve our system. And so, they were very good sports about it. Most people thought this would blow over. And they said, fine, we'll just humor you. And so we set off, and, here's like Teresa with, 4 or 5 of her close friends. But, we brought in a group of about 25 staff members and 14 patients and family members. And they started to talk to each other. And what we realized is that they weren't coming to catch us doing anything. Okay, so this whole worry about this gotcha stuff, this is not, not reality-based, at least in our system it wasn't. And in any other system, and I've talked to lots of them, they weren't finding that either. So this biggest fear that we had, which was like, we can't bring patients and families in the room because they might hear us talking about something going wrong in the system. So do you remember the slide? Like, they're living the system going wrong right now. I mean, it's not going to be a shocker to them. That's, they know the system is broken. Actually, they know it. They know more about this than we do. But, we were like, we don't want them to come in because they might hear about some things that are going wrong in our system. And they said, actually, what we found out is that they wanted meaningful roles. They didn't want to be, an advisory body. Again, I'm going to be very careful with language here because we call patients, our patient and family advisors, partners, because they felt very strongly they didn't want to, make recommendations that would be taken under advisement. They want to be sitting at the table, stay at the table. You don't, invite me in and ask me for some recommendations and then synthesize and decide. We're going to stay here with you, go through the whole process of processing this, this decision making, and we're going to be part of it. So they wanted these meaningful roles. They passionately wanted the system to change. I mean, they weren't angry. These people saw more possibility than we could have ever imagined because they've been living in this system. We're a family practice system, so they're born in this system. Their children are born here, and they're gonna live their whole lives in our system, hopefully. What they wanted, they didn't want to catch us doing anything wrong. They wanted the right care at the right time in the places that they wanted care. So in this particular situation, the behavioral health thing, they didn't want to go to the emergency department. They came for emergency behavioral health service. And we said, we know what's best for you. We need to do a medical screening exam, and that has to occur in the emergency department. So all 600 of you who are coming here every month for behavioral health service, we're gonna move you into the emergency department. We're gonna then separate you from your family members, and then we'll let you know, how it's gonna go. So this was not a good setup, and they wanted to be involved in these rapid improvement events for psychiatric emergency service, and they convinced us then in the first day that we started planning together, they convinced us that we had to have at least 4 more because they knew, they had been trying to change the system forever. We'd been trying to change the system for a month, right? But they've been doing this. They've seen people like us come and go. So they knew right at the outset, we need a commitment from you that we're going to at least be together for 5 or 6 months. These people were very, very smart, much smarter than us. And so here's what it really came down to for us. The patients who were having behavioral health crisis were brought to our medical emergency department. They would either walk in or they would come in by ambulance. It didn't matter if you came voluntarily. We were still going to impose that same rule on you. They were waiting to be seen, and so we were delaying we literally had a built-in delay to the care that they wanted and that they decided that they needed, and or care somebody else decided that they needed because many of them came involuntarily. All right, somebody called the police on them and they came involuntarily. And so even still, when somebody else decided they needed, still we had this delay built in. And for the ones who were coming voluntarily, they left. They were like, I'm leaving, I'll see you later. I don't have time to do this. This isn't what I came for. I didn't come to go to the emergency department. I came for behavioral health service. And so I'm leaving, and likely now we know we're gonna see them later. They're gonna be the ones coming in voluntarily now because we've designed the system, right, to do that. Now we've sort of set the patients up. We've perfectly designed the system to see them later when it's much, much worse. So, really, how do you get through this fog now? This is where we were. Like, I had to throw up a Golden Gate Bridge thing because though I was driving in here today at 6:30 this morning, and I realized you guys have fog too. So, I don't know why from San Francisco, we think we're the only ones with fog. But it was like, oh, right, you're on the water too. But, we really weren't able to see, clearly. And I think this is the challenge for all of us. How do we sort of get through all the muck, and how do we really see? We can identify problems really well. All I had to do was look at the utilization data and the time data. We're all tracking, all of us who have an emergency department, you're all tracking your door-to-floor times, So this group, right, I'm seeing this particular group, and it's like, you can just see their door-to-floor times are, they're not even going door-to-floor, they're going door to the other emergency department. And I'm watching them, in our emergency department. And I do want to say also in the backdrop, to add to the drama, we were a public hospital, and so Contra Costa County had the great luck, or the poor fortune, really, of we were the 7th highest foreclosure rate in the nation. Our county had the 7th highest rate of foreclosure, home foreclosure. So we had lots and lots of employers were pulling out of Contra Costa County. So we were seeing in 2007, 2008, 2009, 2010, a huge surge in utilization of our service because many, many people who were reliant on employer-provided health care now found themselves having to come to the public health system. And so our emergency department was really taking the brunt of that. The waits were long, and so what we were getting at behind the line of the patients and family members who were complaining, right behind that was a line of physicians and nurses for their public comment to say, I need a bigger ER, we need more staff, telling the board, how desperate it was in the emergency department. So this is sort of a perfect storm brewing to basically provide, I would say, very poor care and it really is safety set up from so many angles. So you've got these people in this overrun emergency department. You've got this emergency department trying to get bigger. No one's happy, and I'm trying to figure out, my way through the fog. So I put this up because I'll try to sort of summarize this, but I want to say, does anybody know what this tool is that Teresa and I are holding? Fireman's Axe. Do you know what it's called?
Pulaski.
A Pulaski, yeah. It's called a Pulaski. And so this is a famous tool because there was once a firefighter who, he used this tool and saved a whole bunch of people, and so they named the tool after him, the Pulaski. And the Pulaski, now my husband is a police lieutenant, and so these emergency workers' tools are really important to them. It's also sort of a prestige thing. They've got all their tools hanging on them, and they've got all these things. But I would say it's the same thing with the white coat and the stethoscope. These are our tools, and these are things that kind of separate us. They signal to the world, we're different. This is who we are. It's an identity thing. And for a firefighter too, and like a police officer with their guns, right, these things could save their lives. So they take it very, very seriously. Their equipment is taken very, very seriously. Has anybody ever, I'm going to tell you just very quickly what I opened up with on the Kaizen event. We talked about the Man Gulch fire in 1949. Does anybody know about that? Okay. So if you don't know about it, there's a book called Young Men and Fire written by Norman MacLean. It's a fantastic book. But what it essentially is, it's about, there was a fire burning in Man Gulch, Montana. And at the time, they dropped in smoke jumpers then. These are people, they're dropped in and they go and they kind of fight fires out in the forest. These smoke jumpers, many of them had been military paratroopers, and so they were now a smoke jumping team. They were considered the elite of the elite. But their leader, his name was Wag Dodge, and he was sort of new. So he didn't know, the rules of engagement. Has anybody read David and Goliath from Malcolm Gladwell? No. Well, okay, so those are two books I just recommended. But the new leader, he didn't really know, that he didn't know all the tradition, that he wasn't as steeped in the tradition, but he was very, very clever. And he said they found themselves sort of at the base of the gulch, and they were running for they were trying to run. The fire had turned, and they were going to be overcome by the fire. It became clear. And so they all started to run for the summit. And Wag Dodge ordered everybody, drop your tools, and I'm going to light an escape fire. He had read about it, and so he was going to light a fire and essentially clear an area and stay in that area. And so what happened is that no one listened to him. They continued to run for the ridge, and so Wag Dodge, he did light the fire, and he laid in the patch, the patch. This is now known as an escape fire. He lived, but the 13 other of those smoke jumpers died that day, some of them within a few feet of the ridge, and many of them with still their Pulaskis and their bags on them. These weigh like 50 pounds. They're running up a very steep grade, and they just could not drop their Pulaskis. They couldn't do it. They were not trained to do it. They were trained to hang on to these. And so they carried these things, weighted them down, and they couldn't make the ridge, and they actually died before they hit the ridge. And so what I'm going to say to you today, what I'm suggesting today, is that we have our own Pulaskis, all of us, that we carry. Right? And what I'm going to suggest to you is that we do have an escape fire that we could use. But instead, we're running for the ridge with our Pulaskis in hand, right, when we could just stop. And for us, what it was our escape fire at Contra Costa, it was engaging patients and family members. It was stopping. Quit running for the ridge. Quit running forward, right? If you come in, you go and you go into an improvement team and you say, oh, great, this sounds all really great. Where are the patients and families? They're going to say, well, we have to hurry up and do this. We don't have time. We have to reduce the readmission rate, right? We have to reduce the safety events. They're running for the ridge, right? They're running for the ridge. And really, right in front of you, all around us, we have the ability to actually stop the fire by engaging patients and family members. And so Teresa and I did a little skit about escape fire. It's and if you haven't had it, it's used all the time in healthcare. Don Berwick, he tells the story. He tells it in depth. And there's even, I think, a PBS movie called Escape Fire now. But I don't know if they tell the story of the Man Gulch smoke jumpers, but that's really where it comes from. So anyway, so here we are in the middle of our escape fire, and Teresa says to us, you guys have to stop planning to do your improvement event. The improvement event was designed like this. We're going to have a team that starts to improve right at the door. When the ambulances show up, we're going to make that process efficient. And as soon as then inside of the emergency department, we're going to do this, that, and the other thing, and so on and so forth. And Teresa said, no. It doesn't begin in your emergency department. It begins in my home, in my kitchen. That's where it all starts. Like, you guys don't even know what you're talking about. You're like this much of the situation here. What I live with every day, you're nothing. You're like barely in it. You're a few hours, a month, of my life, but the rest of my life is playing out in my own home. And so she said, if you really want to do this improvement, you needed to have real patients, real family members, law enforcement, ambulance drivers, all of those people, and then after all of that, you bring all those people in, then we can start at your emergency department. And what happened really was, I'm resisting. For those of you who don't know, if you have a chance to go to my blog, you'll find out that I love data, but I didn't bring any data today because I tend to go off on a tangent on data because I love it so much. But what resulted was we ended up putting together a process where we opened our psych emergency to ambulances. That then virtually increased our emergency department, right? It released 14% of the capacity of the emergency department. So that reduced the burden of the emergency department, who was also being overrun. So patients who were waiting for medical service were able to go. Now 600 more beds were opened up in the emergency department, or 600 more visits. Patients who were needing behavioral health service were able to come directly to the psych emergency by ambulance or on foot. And so what we saw was, the length of stay, obviously in the emergency department, profoundly go down, almost to nothing. The left without being seen rate reduced from 10% to below 6%, pretty consistently, and now it's at about 4%. We saw no increase in time spent in the psych emergency, even though they started doing the medical screen there. It didn't change their length of stay there. We saw a reduction in involuntary admissions and an increase in voluntary admissions, which sort of means it's becoming a more welcoming environment. We saw a decrease in calls for help, for behavioral health emergencies or assaults. We saw it goes on and on, what we saw. But what we also saw was patients and family members now on every single improvement team in the psych services and in the emergency services. And then we saw them get pulled out into the other services in the hospital and now in the outpatient. So we just picked one thing and one thing, and then that one thing sort of ended up pulling across our whole system. So Again, like I said, I don't like to do a talk without the patients and family members in the room. So I actually brought a video with me today, just very quickly, to show you, so you could meet some of our patient and family advisors. So I'm going to have Angela turn that on, and it's just a very quick video, but this way you can kind of meet some of these folks. At Contra Costa Regional Medical Center and Health Centers, we embrace the voices of patients, family members, and our community in our improvement efforts. We see their perspective and their voices as essential ingredients in creating a patient-centered health home that's respectful and accessible to everyone in our community.
While I recognize that a lot of providers aren't used to and comfortable with having family members and patients at the internal meetings inside, I feel that it is a shared responsibility for all of us to work together to seek improvements. And I've seen the magic that can happen when people lay down their tools and that aren't working and come together.
As we're involving patients and family members more and more in the improvement work, we're seeing the demand from staff to have patients on their improvement teams. We're seeing that demand increase. And in every case where we've included patients and family members, we've seen powerful results, both in the inpatient and the outpatient.
It's important that we make our voices heard as patients, because the clinics and the hospitals, they can look at it from a professional scale, but they can't look at it from a patient's perspective per se, because they're not the patient.
I'm sure a lot of people think that they are really good and they do their best. And they probably try to do their best, but probably their best is not what we need.
At Contra Costa, I think we're now beginning to understand how to have more meaningful relationships and meaningful conversations with patients and family members. Focus groups and surveys have been what we've relied on for the most part in the past, and those are really important tools. But actually putting patients and family members side by side with staff, working to improve the process, design teams, decision-making teams, that is what can bring about powerful change.
When we really first started this journey, everyone was standing back and just kind of hesitant and just waiting to see what was going to happen. Now I'm just getting staff calling, I need a patient on my team. Is there someone that can, help us?
I think that we've always designed our systems with the best intentions to provide the best care possible. I think we've been doing that, though, without the voices of the patients and family members. Our systems belong to the patients. So by putting the patients and the family members, by bringing them in as partners, we're better able to design systems that provide what they want and they need. And that's why we should do this. That's why we should include patients and families as partners, because these are their health systems. Okay. At Contra Costa Regional Medical Center and Health Center,
I'm turning it off.
The voices
Sorry.
of patients.
There we go. So I just wanted you to meet, and so did they. They wanted you to meet them, some of our patient and family partners. These are the people that really have driven the change in our system. It hasn't been me, it's been them. But I want to leave you with a couple of things. I want to share a couple of parting thoughts with you. And one of them is, what can you do as a leader today? And so I would say, go and see what's actually going on in your system. So I learned when I was in formal education to leadership education, we learned about this concept management by walking around. Go out and do walking rounds and that sort of thing. And one of the things that I learned in studying lean is, and I sort of translated that, is management by standing still. So I would just say, I know that to the leaders and actually all the workers, I know you have, hundreds of tasks waiting for you, or hundreds of emails, or, a day full of meetings waiting for you. But you can't know what's happening unless you go and see. So I think about Taiichi Ohno, who worked at Toyota, and when the young Toyota was going to take over Toyota production, this was sort of one of the grandsons of the original Toyota. Taiichi Ono, who was their improvement expert and their innovative thinker, their thought leader in lean and Toyota production, he took the young Toyota and he took him down to the shop floor. And he stood him on the shop floor and he drew a circle. And he said, "You stand here." And so the young Toyota stood in the circle and said, "Now what do I do?" And he said, "Nothing, just watch." So I would say to the leaders, go down to the shop floor or go to the front line and stand there as long as you can. And this will be hard to do. This will be very hard because you have a lot of demands of your time. But remember, how you spend your time really matters. If you stand in Ono's circle for 1 hour anywhere, your whole system is going to know about that within like 2 days. Everybody's going to know. And so I have actually changed my philosophy that I kind of believe in management by standing still. It's very hard to stand still as a leader. You're being pulled, but until you can stand in the experience of care and until you can stand with the patients, right, they're waiting for us, right? They're there. We're the ones who really aren't there. I mean, I just want to challenge our thinking. It's us that aren't there. The patients are there. They've been there the whole time. They're waiting for you. And they're ready to help you. I was in Los Angeles on Friday, and one of the patient advisors stood up. There was 450 staff in the room, and she said, "Here's what I want you to know. The one thing I want you to know. I am willing to help." Right? That's all she wanted to say. And she said, "I've been trying to tell you this for 10 years. I'm willing to help." But it's really hard to hear that when you're running past, because that's how our system is designed, right? We're supposed to do that. We're the leaders. We have to go here. We have to go there. We have a bunch of things to do. We have emails right now. You know, people expect to hear from you. It's actually not good citizenship not to answer them, right? So you have to do that. But remember, every system is perfectly designed to achieve the results it gets. And our systems are designed, they're designed to separate us from the patients and the family members and their families. They're designed to separate the leaders from the front line, right? We have to redesign our systems to really bring us together. And so I'm going to leave you with I'm going to give you one final example, because kind of going in and going to a care site, you know, and doing improvement. And we have lots and lots of examples of bringing patients in and, you know, reducing the lead time, or, you know, bringing iPads into the cancer center, or, you know, decorating something, or, you know, changing the flow between the emergency department and psych emergency. In med-surg, you know, they've done all kinds of improvements, right? I want to talk to you a little bit about culture, big culture stuff. This stuff that's going to require the highest leadership. I'm going to talk to you about visiting hours. So here was our visiting hour. Yeah, I'm sorry this isn't like a bright enough picture here, but this is a sign that's posted on the wall. It was posted on the wall at Contra Costa. It wasn't just posted on the one wall. It was posted on pretty much every wall at some point, and it's actually also posted outside of every single patient room. I actually have worked at Contra Costa for 20 years, and I didn't see the sign. I never saw it. I never noticed that sign. It wasn't until we had visitors come over, and this was about 3 months ago. 3 months ago, they pointed out to me, "Do you know you have one of these signs about regulating visitors on every wall?" I said, "No, I don't." I had to walk over to the medical center and look to find, you know, to see. This was for postpartum, or for labor and delivery, parents and grandparents only. So, you know, we actually designed our policy that, you know, siblings weren't allowed. Like, we literally designed to keep families separate. I know it's a shameful thing. This is an example of this was our policy, patient visitation. And if I could read to you line for line. It is shameful. But I like this one right here. This was part of the policy, was to control traffic within the hospital. Right? Children under the age of 12 are generally not allowed to visit. I came upon a real story of something that actually happened at our medical center. It was during the H1N1 outbreak a few years ago. And we instituted a policy that children couldn't visit. Did any of you do that? Any of your? Yes, you're nodding. So did we. And I found out that a gentleman, a grandfather was in the ICU. This grandfather had raised his grandson. The parents were not involved in his upbringing thus far for whatever reason. And so the grandfather was the primary care provider of this young boy. And the grandfather fell ill with something completely different. It ended up that he was in our intensive care unit. And this was in the height of the H1N1. And his 8-year-old grandson, who he had driven to school every single day of his whole school life and preschool before that, who he had made lunch for every single day, who he read a book to every single night, his grandson was not allowed to visit him. And he passed away in our facility, and the grandson was not allowed to say goodbye to him because of our visitation policy and our infection control policy, right? And so as we sort of sat down and we considered this now a never event. When we found out about this, as we started to look at this, we realized this has to be a never event. This can never, ever happen again. I mean, you think about it, we weren't saying don't do infection control, and we weren't saying, just have open visitation with no kind of boundaries on it. We could have masked the boy could have worn a mask and come in and seen his grandfather. I mean, there were basic things that we could have done. We just didn't do because our system wasn't designed to prevent the child from seeing his grandfather. Our system was designed to prevent them from saying goodbye. That's the truth. I could reframe this in a nicer way. I probably did reframe it in a nicer way. In fact, I did reframe it in a nicer way. But the truth is our system was designed to do that. That's unacceptable. Unacceptable. So we set off on a journey. We don't have private rooms. We don't have, we don't have very many resources. We're a public hospital. So, kind of traditionally, we're underfunded and we don't have, slick facilities. But we decided it didn't matter. We were going to take this on. This wasn't going to happen anymore. So we actually transformed our visitation policy into a welcoming policy. And so we don't have visitors at Contra Costa anymore. No one is considered a visitor. We don't even use the term visitor, although we had to put, if you go onto our website now, it'll say right here over the thing, it'll say in parentheses, former visitor policy, because one of our board members said, nobody's going to get this, Anna. This is so far over the edge that nobody's going to understand. So at least if you could tell people that this new welcoming policy is the reinvention of the visitor policy, because they're going to still be looking for the visitor policy. We don't have that anymore. There's no such thing as a visitor at Contra Costa. And we put drafts. We opened this up on the World Wide Web. We put drafts of all of our welcoming policy, all of the data collection, how we're collecting the data on that. And I'll just say, in the first 3 days of we instituted this September 17th. So it took us 3 years to do this, but we didn't stop. We brought in security. We had to bring our security team in, our nurse team in, doctor team in, leadership team in, outside community members, patients' families. It could have never happened had we not involved the patients and family members. It would have never happened. We would have talked about it forever. First 3 days, we had 46 family members stay part of or all of the night, and a pizza delivery guy bring pizza. I checked on it last week, or on last Monday, and by then, remember we initiated this September 17th, we had 341 people stay either all or part of the night. And what we realize is, even on the very, very rare and unique occasions that we cannot accommodate family presence at the bedside for some safety reason or there's some reason, which is very rare. We actually haven't really had those come up yet, but even when we can still be welcoming all the time. We can design our system, we can redesign our system to welcome patients and family members in. And we started to look, and we now have a whole committee with patients and family members on it. They're looking at every single one of our policies, and let me tell you, almost all of them look as bad as the visitor policy. And probably, I'm just going to say, go back and look at yours. I won't say what yours look like, but go back and look at yours and ask if the structures that we all rely on that literally direct staff, the foundation that guides staff, Go look at them and find out if they're patient and family centered. And I'm just going to tell you one other thing. You can't look at them without a patient or a family member because you won't be able to see it because it takes a while to develop new eyes. So what we learned is that patient and family involvement is essential to transforming not only our hospital, but I believe any hospital, all hospitals. There's no health system that can transform themselves without engaging patient and family members. It just can't happen. I think you need to start before you're ready, and I think you've already started here. I mean, obviously, this is, you're really, I think you're leaders here, here in Oregon. You lead by example, and I'm talking to the leaders, and I'm talking to the frontline staff, but go and see, and then stand still. When you go through your email, think about, I know when you read it, you want to answer it. Well, I'm telling you, I think you should take the time to answer it, and make it meaningful. Make it meaningful for the frontline staff. Make it meaningful for the patients and family members. Don't just give them sort of a token title. Actually decide with them. Let them have decision-making power and ability. Okay, so I'm just encouraging you to be bold. I don't know, for us, taking on the visitation was a huge sort of thing. I want you to be, but whatever it is you do, be really bold when you do it. Step out there and hold your ground, right? Be really, really clear. We changed all the signs in the hospital. They all say welcome. Everywhere you go, everybody is welcome all the time, right? Collect data. Talk about your data. Put it on your blog, on your Twitter page, on your newsletter. Post it just on your improvement boards. Right? And finally, you're going to need to be brave. This isn't work for the faint-hearted. That's a little police humor I'd like to. You're going to face resistance. It's even, particularly, some people may think you may be called radical or passionate. That's my favorite word, that, she's really passionate, about, what does that mean? But remember, science is on your side. Science is on your side because all evidence says engaging patients and family members, all evidence clearly demonstrates that it actually improves health, improves outcomes. This is a huge piece. I don't know. Again, I'm making an assumption, but I come from a resource-strapped environment, and the single most powerful accelerant to change is engaging patients and family members. It's also the single largest untapped resource in our communities and in our health systems. So remember, the most precious gift you can give as a leader is your time and your attention. Thank you so much for having me today. Thank you. I don't know if Okay, I think we have 5 minutes. We have about 5 minutes for questions.
Does anybody have any?
Okay, now I get to run.
My name is Paul Conti. I'm on the PeaceHealth Advisory Committee, and thanks very much. I really enjoyed a lot out of your talk. Could you speak a little bit to, and this isn't particularly about our situation, but I think I've seen in a lot of places, organization like a hospital wants to decides, okay, they want to engage patients and family members, but the way they do it is they set up an intermediate committee, and so they put people on that, and then what ends up happening is you end up with a committee in which they can be ignored, pat on the head and ignored by during actual decisions, because they're not really at the table like you were describing during the decision. And on the other hand, what I've seen happen, again, not really talking about our situation, but is that they become sort of part of the problem because they no longer are the raw patient experience, but now they have a role, and their role has to be one of balance and so on. And so you end up with this intermediary, which on the face of it would look like it's helping, but isn't really the same as putting patients right at the table during the decision process. Could you speak a little bit to your experience and advice on that?
Yeah, that's a great point, and that's a great I think those are great observations, and I share your feelings about that. I think that there are a lot of systems that have, you know, advisory bodies, and that's what they are. They're advisory bodies, and they aren't necessarily engaging in shared decision making. I don't have the solution to that. I do know it happens, and I guess I would just say again that to the patient and family partners or leaders or advisors in the room, you have so much to offer all of us, and we need you. And even whether we tell you that or not, whether we know how to tell you that or not, we do need you. And so I would just encourage you to keep pushing forward and keep reaching out. And to the leaders in the room, I would just say, please stop what you're doing and just look around, because I think there are probably patient and family partners right around you who are trying to connect with you, who are actually really going to become invaluable resources to being able to reach things that have been out of our reach until now. And so I don't have the answer to that. I think many more people are doing that, you know, kind of I have a patient and family advisory body, check the box, than actually bringing patients and families in the room. One of the things I did, and it's, you know, it's just one of the things that we did, we actually set aside 2 seats at the C-suite level for our health system. That would be the clinic system and the hospital system, the delivery system, for patient and family advisors. And then we went to the patient and family partners and said, you nominate whoever you want. And these people are on the C-suite team. So they come to the strategy sessions. They come to the weekly. We don't have meetings without them. The only thing that we meet about without them is personnel things. Otherwise, everything else, budget, everything else, they're in the meeting. Root cause analysis, big safety events, all that, they're there. But they're not in the personnel things. And actually, they didn't want to be. They were like, I don't want to be in this. I don't, you know. But they do help us do interviewing and that sort of thing. But they don't do personnel action stuff with us. That's the only place they're not there. So I'm sorry I can't, you know, offer something more. But I think just bringing them in meaningful roles. Yeah. Thank you. Thank you. Thank you. Thank you so much.
Thank you.